Welcome to the Canadian Cardiovascular Critical Care Society videos, a new tool to share complex critical care concepts. A cardiovascular trainee and an expert mentor will present a review of the current physiology with relevant literature. You could submit a future topic by contacting us by email info@cancaresociety.com.
Hi everyone, my name is Vincent Chauvette from Montreal University, and today we'll discuss differential hypoxemia. Before going any further, let's first review what differential hypoxemia is and how it can occur. Differential hypoxemia is a complication that can occur following the installation of peripheral extracorporeal membrane oxygenation, also known as ECMO, in patients with concomitant heart and lung failure. It is often referred to as North-South syndrome or Harlequin syndrome, although differential hypoxemia probably best describes the pathophysiology underlying this condition. It has a reported incidence of approximately 5 to 10% in the most recent literature. Several aspects of this phenomenon should be stressed before digging different ways of addressing this issue. First, differential hypoxemia should be recognized as an early sign of cardiac recovery in the context of ongoing pulmonary failure. Because of ongoing lung failure, the blood that reaches the left atrium is only partially oxygenated. This blood then makes its way through the left ventricle and is ejected in the systemic circulation by the recovering heart. This is illustrated on this figure from Spengler and Associate, showing that the left ventricle is ejecting blood with a saturation between 50 and 70%. It should also be emphasized that this complication is encountered in the context of peripheral ECMO and the formation of a dual circulation. The deoxygenated blood from the upper body is drained in the superior vena cava, returns to the right atrium, goes through the pulmonary circulation where gas exchange is impeded, before going back to the left atrium and left ventricle, where it is ejected in the ascending aorta. Meanwhile, the deoxygenated blood from the lower body is drained by the cannula placed in the inferior vena cava. The blood is oxygenated inside the ECMO system and is pumped back into the arterial cannula, usually located in the contralateral femoral artery. This results in differential hypoxemia, where the upper body receives blood pumped by the recovering left ventricle, while the lower body is supplied by the ECMO. The blood from the left ventricle and the ECMO mix together at some point between the proximal aorta and the arterial cannula. This concept is beautifully illustrated in this image published by Saint-Arnaud and Associate. As you can see, the recovering heart was injected and thus the blood coming from the LV appears white on this illustration and the blood from the ECMO system appears black. In this specific case, the mixing occurs right below the level of the left renal artery. Now that we've exposed the mechanism and physiology of differential hypoxemia, let's discuss its impact. Although ejection from the left ventricle is a sign of cardiac recovery, it can lead to organ hypoxia if differential hypoxemia is left unrecognized. In fact, as previously demonstrated, deoxygenated blood is pumped in the ascending aorta and feeds into the coronary arteries, the brachiocephalic trunk, the carotid artery, and potentially further down the aorta. If left untreated, local desaturation will lead to cardiac, muscular, nervous and cerebral damage, as illustrated on this image published by Pagria and Associates. On this figure, the ECMO was injected and thus the oxygenated blood appears white. The deoxygenated blood coming from the recovering LV appears black. The figure clearly illustrates how differential hypoxemia can lead to upper body hypoxia. Notice the deoxygenated blood flowing through the brachiocephalic trunk and into the cerebral circulation. Meanwhile, oxygenated blood from the ECMO enters the left subclavian artery. Therefore, complete monitoring is critical to ensure early recognition. In order to detect differential hypoxemia early on, it is crucial to monitor the saturation of the upper body as well as cardiac function. Upper body saturation can be monitored using a variety of measurements. It is recommended to insert a right arm arterial cannula in patients with peripheral ECMO. This allows indirect monitoring of the blood saturation in the brachiocephalic trunk. Monitoring of limb and cerebral saturation can also be obtained using various types of oximeters. Near-infrared spectroscopy is often used to monitor cerebral and limb ischemia. 2 sensors are placed on the forehead and 1 on each leg. This configuration allows close monitoring of the lower body as well as both cerebral hemispheres. Pre-oxygenators SVO2 should also be monitored as they tend to increase due to lower oxygen extraction in patients with differential hypoxemia. It is best to combine several monitoring methods in order to rapidly detect and correct this complication. Now, focusing on the treatment, the problem with differential hypoxemia lies in the fact that the left ventricle is ejecting deoxygenated blood. Therefore, it can be corrected either by increasing the oxygenation of the blood coming through the pulmonary circulation or by decreasing the amount of deoxygenated blood ejected by the left ventricle. Because the problem is one of saturation, the first step in addressing differential hypoxemia should be to optimize ventilation and gas exchange. Increasing the FiO2 is an initial step. Performing a bronchoscopy, starting antibiotic treatment, initiating diuretics, draining a pneumothorax or pleural effusion are all important therapeutic tools to consider depending on the situation leading to differential hypoxemia. If these initial steps fail to correct upper body desaturation, advanced therapies should be rapidly initiated. Increasing the pulm flow will allow better venous drainage, which will decrease the amount of blood going through the pulmonary circulation. This will also increase the blood flow coming out of the arterial cannula, which will allow better oxygenation of the upper body. However, this solution, although simple, is associated with several potential complications. In fact, the increased afterload generated by the arterial cannula will result in increased strain on the left ventricle and limit its recovery. Furthermore, increasing the blood flow from the reperfusion cannula might result in LV distension, which can in turn exacerbate lung injury. Thus, a strategy of LV venting should also be considered simultaneously. In fact, a recent article from Russo and Associates demonstrated the benefits of LV venting in patients undergoing ECMO after a cardiogenic shock. Venting can be performed either percutaneously or surgically. The sites of venting include the aorta, the left ventricle itself, the left atrium either through a right superior pulmonary vein or with a transatrial septostomy, the pulmonary artery, and the right atrium. Concomitantly, a gradual decrease in inotropic support can be attempted in order to decrease the amount of blood pumped by the left ventricle. Finally, the blood saturation in the left ventricle can be increased using a venous reperfusion cannula installed in the superior vena cava. This configuration is known as Veno-Arterial ECMO and requires the installation of a Y connector on the outflow cannula. Using this configuration, fully oxygenated blood can be delivered both to the lower body and the pulmonary circulation. Flow adjustments can be made in order to modulate the amount of blood going through each part of the circuit. Eventually, the Veno-Arterial ECMO can be used to bridge a patient to a more conventional veno-venous ECMO once the heart has fully recovered. An in-depth description of this specific strategy can be found in the Interactive Cardiovascular and Thoracic Surgery Journal. On the image below, notice the occluder device on the inflow cannula, allowing gradual weaning of the arteriovenous ECMO. In conclusion, differential hypoxemia is a serious complication of VA ECMO. It occurs in the context of concomitant heart and lung failure and can be detected using readily available monitoring tools. Early detection and early treatment are key to prevent the consequences associated with this complication. Thank you for watching.
On behalf of CANCARE Society, I hope you enjoyed this video and thanks for watching. You could submit a future topic by contacting us via email info@cancaresociety.com.